I have had a special request to talk about the antibiotics at our facility that count as broad spectrum antibiotics in sepsis. And those are meropenem, cefepime, ceftriaxone, zosyn, and levaquin. Some of those we can give IV push. Levaquin we can't give IV push, which doesn't matter because levaquin's trash anyway. Zosyn we can't give IV push at this time because of some corporate restrictions, so don't worry about that. But the other ones we all can. So cefepime, ceftriaxone, and meropenem we can all give IV push. So questions like, how do I know if my patient has been given multiple antibiotic orders and they're all stat? How do I know which one to give first? So I have a couple thoughts on that. First of all, a great rule of thumb is the one you can give the fastest is the one you should give first. So if I have, for example, cefepime and vancomycin ordered, vancomycin is given over several hours, and so vancomycin would be a great one to give second. The other thing with vancomycin is that it treats 1, 2, maybe 3 bugs well, all of which are given, we're giving vancomycin really as a CYA. And so it's covering things like MRSA in case it's there, and in very few cases is it actually there. And it covers nothing else. So no gram negatives, none of the most common causative agents like strep pneumo. And so it really is, like I said, kind of a cover your backside agent, and it's given over several hours. So it should never be the one that we give first. Things like clindamycin also are given over extended amounts of time and really does nothing well, especially in a world where we're giving linezolid for toxin control or toxin treatment. Clindamycin really does nothing well except cause C. diff. So clindamycin should never be one that we give first. The other question I get sometimes is, how do I know like which one my doctor's gonna choose? Like I know I need to give a broad spectrum, and so I wanna go get Rosefin ready, and then they choose cefepime instead. How would I have known that that was gonna happen? And so there's some nuances there that are maybe a little bit beyond the scope of this video, but it has a lot to do with the source. So for example, Rosefin, in a nursing home patient or in a diabetic foot infection or whatever really wouldn't be a great choice because it doesn't cover a lot of the bugs that are there. It doesn't cover Pseudomonas. It's not most commonly used for like skin and soft tissue infections because it focuses more on some of the really basic gram negatives like E. coli or things that I might find in like the urinary tract, but I'm not really going to find on like the surface of the skin. Like it doesn't cover MRSA. It doesn't cover like Pseudomonas, like I said. So it really depends on the type of infection that I'm treating. And so if I have a nursing home patient or I have a diabetic foot infection where I want Pseudomonas, I want really great gram positive, that was kind of all over the place on both sides of the spectrum, then Rosefin might not be a great choice. And so that's why you might find cefepime. Meropenem is really the far side of things that my patient either really has a significant penicillin allergy, where I'm afraid to even use cephalosporins like cefepime or Rosefin, or they have a history of ESBL, which is a kind of a complex or extensive drug resistance profile. And so they're going to be resistant to cefepime and Rosefin. And so I have to use meropenem. And so meropenem is kind of a last resort. And so I don't know if that helps or not, but give the fastest one first, the one that I can infuse the fastest first. And then as far as which antibiotic my doctor is going to choose, it really depends on the type of infection. And so they're not just trying to confuse you, but it really does depend on what type of infection we're trying to treat. I hope that helps. Farm ER.